I would really like to welcome you to the first episode of the UEG Policy webinar. My name is Alexander Hann. I'm a gastroenterologist from Germany, that's in Bavaria, and I'm chairing the United European Gastroenterology, so UEG Public Affairs Group. And our topic today is healthy hearts, healthy guts. And we will discuss the EU Safe Hearts Plan and initiatives from the Non-Communicable Diseases Alliance and how they can improve digestive health. And I'm really happy that so many of you showed up this morning to discuss with us this very important topic. Together with me is MEP Romana Jerković. Hello, Romana.
Hello, good morning to everyone.
And we have Liz Arnanz from the NCD Alliance.
Hello, everyone. Thanks so much for the invitation.
So in the beginning, I would like to outline the program for you, and we start we build the webinar like this, that we start with the two talks. First, Romana will tell us more about the EU Safe Hearts plans, its objectives and scope, and we're going to touch upon topics like prevention and shared risk factors that contribute to other diseases like cancer. And then we're going to switch over to our second guest, Liz, she will tell us more about also risk factors, and we will learn more about what NCDs are. In the end, it's an incredible important collection of diseases like cardiovascular diseases, diabetes, cancer, mental and neurological conditions. And after the two talks, we will have time for discussions. So please write your questions into the chat. And Anna Carboni from our UEG headquarters in Vienna will be so kind to help us not to forget any of your questions and comments. But let's start with the webinar and with MEP Romana Jerković. She's a Croatian politician and in the European Parliament since 2020, and she's vice chair of the SAND committee, so the Committee on Public Health, and member of the ENVI committee, so the Committee for on the Environment, Climate and Food Safety. But even more important for us as UEG, she chairs the MEP Digestive Health Group. It's really a pleasure to have you on our show. So the stage is yours, Romana.
Thank you, Alexander, and good morning, everyone, once again, and thank you so much for the invitation. It's a pleasure to be here, as I said, and to be able to present the ongoing work on the cardiovascular diseases. So, as you know, despite significant clinical and technological advances, the overall burden of cardiovascular diseases remains still unacceptably high, and disparities between member states still persist. Moreover, fragmented national approaches are not sufficient, obviously, to address the challenge of this scale. Therefore, adopting a comprehensive and EU-wide strategy to support member states was long overdue. So in December of the last year, European Commission presented the Safe Hearts Plan as a structured response, bringing together prevention and early detection and integrated care into one framework. The plan identifies, I would say, a key structural weaknesses: insufficient emphasis on prevention, late diagnosis, fragmented continuity of care, digital fragmentation, research gaps, and persistent inequalities across the EU. Most importantly, it introduces 10 flagship initiatives intended to address these shortcomings. However, I would say that this strategic framework is only a starting point. Yeah, good starting point. But obviously its effectiveness will depend entirely on implementation, measurable targets, and political accountability. And this is where the role of the European Parliament comes in. As a rapporteur for the cardiovascular health strategy, my task has been to strengthen this framework, to identify where the Commission's proposal requires a little bit more courage, a greater specificity, where it lacks enforceability, and where additional policy tools are necessary. And after consultations with clinicians, with researchers, patient representatives across the member states, several priorities have emerged, particularly when it comes to prevention. So I would like to present these priorities of the European Parliament. First, our key, our approach. We were aware that our approach requires really a structural policy change. Cardiovascular risk is not only a matter of individual choice. It is strongly shaped by commercial determinants, and the aggressive marketing of tobacco and nicotine products, alcohol, and unhealthy food continues to drive unhealthy choices. So our approach to prevention, I don't know if I mentioned the word prevention, our approach to prevention needed a structural change. So maybe the biggest effort that we need to do is in the prevention. So every time when I mentioned in the Parliament, industry, which has a huge deal of responsibility, some of my colleagues point to individual responsibility. Of course, individuals matters. And each of us has a responsibility to make choices that protect our health. But we also must be honest. These choices are not made in a vacuum. They are shaped by very sophisticated marketing strategies, and which influence consumers' choices, often at a subconscious level. And if the environments in which we live promote unhealthy products, then we cannot realistically expect individuals alone to carry the burden of prevention. And that is why the balance today is not where it should be. We are still too focused on individual behavior and not ambitious enough when it comes to shaping healthier environments. We need stronger rules on marketing, stronger rules of better consumer protection, and clear science-based standards. Because otherwise, we are asking people to make the right choices in an environment that is designed to push them into the opposite direction. So, we need to be honest about the responsibility. Industry has a role, but voluntary action obviously will not be enough. So we need a regulation. Second, the first was prevention. I was talking about the prevention. Second is environmental determinants that must be recognized explicitly within cardiovascular policy. Air pollution, noise exposure, extreme heat and chemical exposure significantly contribute to cardiovascular morbidity and mortality. So again, individuals cannot meaningfully mitigate these risks on their own. This makes regulatory intervention essential. Then third, the gender gap. Cardiovascular disease remain underdiagnosed and undertreated in women. We know that women are underrepresented in clinical trials, and diagnostic criteria are frequently derived from predominantly male study populations, and this needs to be changed. We must require sex disaggregated data collection, integrate women's cardiovascular health into research funding priorities, and so on. Fourth, the Save Heart Plan rightly recognizes the potential of digital technology to strengthen cardiovascular care, particularly in regions with limited access to specialized services. However, the role of digital tools, telemedicine, artificial intelligence must be clearly defined. Technology should support clinical decision-making, yes, streamline workflows and improve data integration, but not to replace clinical expertise or weaken the doctor-patient relationship. Fifth, inequalities. Inequalities between and within member states, this remains substantial. Cardiovascular mortality rates vary significantly across the Union. So this is also something that require our full attention and action. Finally, cardiovascular diseases, as you perfectly know, rarely exist in isolation. It coexists with so many other diseases: diabetes, obesity, chronic kidney diseases, gastrointestinal cancers, inflammatory bowel disorders, and so on. So these conditions are linked through shared risk factors. We have to understand that we have shared risk factors: unhealthy diet, alcohol consumption, obesity, and metabolic dysfunction, but also increasingly through shared biological pathways, including chronic inflammation and the gut-heart axis. So health systems structured around single disease are poorly equipped to manage these complex patients. Now, with the Save Heart Plan, we finally can change all this by focusing on prevention and risk factors. It provides a natural entry point, I would say, for cross-disease strategies. Measures such as improving nutrition, reducing alcohol consumption, or addressing obesity will simultaneously benefit cardiovascular and digestive health. So we must develop care pathways that connect cardiology, gastroenterology, and primary care, improving training in comprehensive risk assessment and recognizing that addressing digestive health is not, it's simply not separate from cardiovascular prevention, but an essential part of it. So this plan, the Save Hearts Plan, it really creates an important opportunity for all of us, opportunity to change these problems by focusing on prevention and risk factors. We will deal with so many diseases in the same time. Well, however, the reality is that health is being marginalized in the EU budget. Unfortunately, I'm so sad to say that. And it is likely that it will receive significantly less funding than in the previous mandate, in the previous multi-annual financial framework. This means we must be more focused, more strategic, more determined than ever. In the European Parliament, we will work to secure the strongest possible financial and political commitment for cardiovascular health. But this effort cannot succeed at EU level alone. We also need your engagement and your help. We need clinicians and scientific society to speak clearly, to speak loud to national governments and European representatives to ensure that both cardiovascular and digestive health remain central policy priorities, because only if we are coordinated, if we work together, if we have united approach across the institutions, member states, and the clinical community, we can achieve structural change. And that is what we need, structural change. Thank you, Alexander, so much. I hope I didn't exceed much my time.
No, no, not at all. It was really impressive. So thank you. It was a great speech. I think we learned a lot about that we move away from just focusing on treatment and go towards like where the root is, like prevention, early diagnosis. Very, very impressive. And it perfectly fits also just a very small remark before Liz starts. The UEG has those two position papers just published. One is about transforming food systems for digestive health, and it's about ultra-processed foods. To like talk to politicians and say how important it is to change the unhealthy diets. And the other one is about digestive cancer screening across Europe to identify cancers in high-risk populations, or not everybody, but really people that are on risk earlier. So very impressive, Romana. We move over to our next speaker, Liz, and so Liz is from the NCD Alliance, and she's responsible for policy and advocacy work on NCD prevention and health promotion. And in the end, her main aim, or one of the main aims of the NCD Alliance, is to reduce exposure to the main NCD risk factors and to address the social and commercial determinants of health. And we will hear more about this in her talk. And she holds a master degree in European Interdisciplinary Studies from the College of Europe. So we are very happy to have you on the show today. And I already had a sneak preview into your slides, and I'm really also looking forward to hear your talk. I think it will be really great and engaging for everybody.
Thank you, Alexander, and hello everyone again. It was very inspiring to hear you, Mrs. Jerković. It's always a pleasure to hear decision makers talk about NCD prevention as a structural issue and not an individual choice one, and the need to have a balanced policy approach to this important conversation. So again, thanks for the opportunity to talk about the importance of health promotion and NCD prevention for digestive health today. And I just wanted to provide a bit of background about NCD Alliance for those who don't know our work. But Alexander, you already did mention a bit the fact that we are very much focused on NCD prevention and control. So if you go to the next slide. So this is just an overview of who we are. So we are a global society network. Even though my background is more on EU policy, it's been a long time I haven't worked on EU policy, and I sometimes miss it, especially when I hear about all the developments on health despite the budget constraints. But we very much focus on advocacy and policy development at the global level. And we collaborate with a network of national and regional NCD Alliance to support national advocacy efforts as well. And we also have work around the meaningful engagement of people with lived experiences, as this is crucial for effective policy. And I was very glad to hear Mrs. Jerković about the fact that you've been consulting different civil society organizations about the response on the Safe Hearts plan, as this is very much one of the key calls we have in our work. In the next slide, I just want to provide a bit of an overview about the NCD burden. I think it's important to reiterate the fact that they are the world's biggest killers in terms of mortality burden, but and the trend is increasing. And just to say, the figures you see on the slide only capture mortality. It does not reflect the full burden of morbidity, disability, and the long-term strain that these diseases have on individuals, communities, and health systems. And I think, Mrs. Jerković, you were very strong in pointing to the inequality of impact of these conditions. not just between countries, but within countries. And I think this is important as well to keep in mind. And then another aspect, including with cardiovascular diseases, is the fact that and digestive health is that a large proportion of the NCD burden is preventable, and therefore and we have tools, policies, marketing restrictions, as you were mentioning, that are effective and well proven in different places in the world. So it's a matter of political will and not necessarily of lack of solutions to this problem. And just to say, despite this, both domestic health budgets and also you were mentioning the EU budget and global health financing often remain very misaligned with the scale of the challenge. Allocations really don't match the burden. So in the next slide, I want to flag the fact that give an overview of how we work as a movement. So we are an umbrella organization with over 500 members, and bringing the diverse constituencies, covering many diseases, risk factors, and population groups. So what unites our diversity is really a focus on shared risk factors. You already mentioned many of them. I don't want to go on detail. I will be focusing on alcohol use and unhealthy diets in my presentation, just because I appreciate those are two very major risk factors for digestive conditions. But I was very glad to hear from you, Mrs. Jerković, to mention the air pollution as a growing risk factor that right now, in terms of mortality, is at the same level as tobacco use, and usually is more dealt by environmental authorities, but it's also a health imperative to act on environmental risk factors. So I was very glad to hear that during your intervention. And so addressing these risk factors has a broad impact across many conditions, as you were also referring before. And it is important also to look at this across people living already with NCDs, because that helps prevent comorbidities, as we were mentioning before. And another thing that unites our movement is really focusing on shared system-wide solutions for the health system, the health sector, sorry. So improving access to essential medicines that can have can improve the management of several conditions, strengthening health systems through referral systems, for instance, and hastening surveillance, and ensuring more appropriate allocation of resources to NCD services. You were also referring to the need for more gender-sensitive policies, balanced approach with digital health tools. So all of this kind of different approaches can bring benefits across all these conditions, are sometimes very diverse. It is important, the framing, as you were saying, and I was so glad to hear, that we tend to hear so much about NCDs as a lifestyle choice. And we as an organization really strongly challenge this framing, because it does risk obscuring the role of environments and policies that shape actually our behavior. If you don't have access to fresh food, or they are extremely expensive, or if, soda drinks are sort of the same price as water, that tends of making certain things the default choice rather than the one that I want to choose because it's my decision, right? So it is that framing of individual responsibility is really shifting the responsibility away from decision makers, and NCDs should be understood as a political responsibility. And language matters here. And I just wanted to flag also the fact that you will see alcohol use looks a bit different in my slide, and it's because we used to tend to say harmful use of alcohol, but this is a completely misleading term. For instance, evidence is really showing increasingly that there is no completely safe level of alcohol consumption. And alcohol right now is linked to at least 7 types of cancer directly, even at at moderate consumption levels. And many of those cancers linked to the digestive tract. So, and awareness is low. So I think it's very important that we use the right terms when referring to NCDs and the risk factors. So in the next slide, I think I already made this point, but I really want to flag the importance that we tend to see health promotion and prevention very early in the stages of the continuum of care. But it's important to look at health promotion and NCD prevention as something that is relevant across the continuum, because people living with NCDs also have a right to health promotion and NCD prevention services, as they play a critical role in improving their prognosis, preventing complications, and reducing the risk of comorbidities. And it's also important to broaden how we think about universal health coverage. UHC is often seen as a responsibility of the health sector alone, but many other sectors such as education, agriculture, finance, and urban planning play a role in shaping health outcomes by improving the environments we live in. And so I think this is important to keep in mind as we go into my future reflections. So if you can go to the next slide. So a key, and I was glad to hear Mrs. Jerković talking about industry, because I think it's important to recognize the fact that many NCDs are preventable and are linked to modifiable, and these risk factors that we've pointed out are modifiable. And a critical driver of these risk factors is the commercial determinants of health. WHO defines this as activities of private sector that affect health either positively or negatively, and directly or indirectly. By direct influence, we are referring, for instance, to marketing of unhealthy products, but then also indirect influences would be industries trying to shape and weakening public health policies. And it's important to clarify that the NC movement is not an anti-business movement. So we usually are tagged like that. On the contrary, the goal is to ensure that economic policies and incentives are aligned with health outcomes, basically. So a healthier population does support productivity. Subsidies can be directed to profitable health promoting activities. And for instance, taxation has a very important role to ensure that the real cost of harmful products is not externalized onto individuals and public systems later on when diseases outcomes happen. And so while determinants of health sometimes can have positive effects, obviously, our policy focuses very much on addressing the negative impacts. And I really encourage you to have a look at the Lancet series on commercial determinants from 2023, if you are familiar with it, that I'm showing on the slide. And with the diagrams that you see on the slide, I want to show also the global nature of this issue. So much of the world's alcohol and ultra-processed food supply is controlled by a relatively small number of multinational companies. And I think this is important to highlight because NCDs are not purely a domestic issue, but part of a broader cross-border challenge. And I'm saying this because NCDs often we are told this shouldn't be a priority in global health because they are not a threat across borders, but there is actually a lot of cross-border considerations to take in mind. So in the next slide, I want to be a bit more positive and say we do have regulations that and policies that are evidence-based, highly cost-effective. There are the WHO NC Best Buys, which is a menu of cost-effective interventions. They have a cost-effectiveness analysis. These include many measures such as taxation on unhealthy products, restrictions on marketing, and policies to promote healthier diets. I'm showing the ones on alcohol and healthier diets. And we tend to, this is very much our pillar for NCD prevention advocacy, and it's a very helpful tool for countries to identify priority interventions because they are often otherwise overwhelmed by the amount of actions that we are recommending. And it's very important to flag that some recommendations may have lower cost effectiveness in their analysis or are recommended, but they don't have a cost effectiveness analysis. And this is not because they are not effective, but just we need more available evidence. And in the next slide, just to reiterate that as an umbrella organization, we have been aiming to identify and promote policies that are relevant across multiple risk factors. So in the recent years, we've been focusing on 3 key areas: marketing, labeling, and fiscal policies. And we did develop these reports, and I'm happy to share the links afterwards. But I will be very brief on introducing this. So next slide, Alexander. So on the marketing policy front, our work did highlight the complexity of modern marketing practices, and the importance that marketing is just not limited to advertising. It includes product design, placement, pricing strategies. Children are particularly vulnerable to these influences, and effective policies therefore need to go beyond child-specific settings as well. And address broader environments where they are exposed, like sports and digital platforms. And regulations on marketing need to consider techniques that are especially appealing to young people, like the use of cartoons, celebrities, or influencers. And some key recommendations of our report include the use of technology-neutral language in marketing regulations to keep pace with evolving channels. Also involving young people in policy design, because they are the ones that really better understand their exposure, and also look at the role of general marketing regulations beyond specific products that can have positive impact on monitoring and enforcement, like disclosure obligations by companies, including social media on advertising spending, content, etc. In the next slide, just an overview of what we recently did on labeling. So we did focus on analyzing different approaches to mandatory warning labels as a tool to reduce consumption of unhealthy products, building on the experience of tobacco graphic warning labels. And there has been progress in front of packaged food labeling, including in Europe with systems like Nutri-Score, but many of these remain voluntary. And as Ms. Jerković really flagged, voluntary approaches are the evidence shows they don't work, and also implementation tends to be inconsistent, which can lead also to consumers' misinformation. And so mandatory warning labels on food, such as the octagonal warning system that is commonly seen in Latin America, and it was first introduced in Chile in 2016, have shown very strong impact because of the model itself, but also because of the mandatory nature, of course. And we're beginning to see also interest in similar approaches in other regions of the world, although to my knowledge yet it hasn't been legislated anywhere else beyond the Americas. And an important insight from this report and the experience of Latin America was that combining labeling with policies of other nature, like marketing restrictions, can really increase the impact. So as you can see, there is the same brand of cereals on the picture, but in some of the Latin American countries that have added these warning labels, they've also added that those products with labels should have a ban on the use of child-appealing content. So you can see how different the same product looks in different countries with this more comprehensive approach to labeling. And at the same time, also our report looked at alcohol labeling, which is an area that is much more neglected. And this is striking given the clear health risk of alcohol and the low public awareness, and particularly regarding low levels of consumption. And so on the image here, I want to show how a low alcohol drink, so for context, in the EU, a drink below 1.2% of alcohol by volume is considered non-alcoholic. So you can see a low alcohol drink where it's compulsory to have a list of ingredients, a nutrient declaration, versus an alcoholic cider where the information is not compulsory. There is a list of ingredients there, but in many countries it's not, and you can see in the ingredients it has sugar, but then you have no obligation to have a nutrient declaration, which seems a bit of a lack of consumer information. So in Europe, this is an ongoing policy debate building on Europe's Beating Cancer plan as well, and Ireland is expected to be the first country to introduce comprehensive mandatory alcohol labeling, including cancer warnings in the coming years. In the next slide, very brief overview of what we did on fiscal policies. So this is our most recent work. And I just listed the fact that we look across not just health taxes, but also the broader fiscal environment. So how subsidies and tax exemptions can also have an impact on health outcomes. And health taxes are one of the most cost-effective tools in reducing NCDs. But also can generate revenue for health and social programs. So I wanted to show on the right a table of an article that is comparing SSB tax models in Europe, where you can see some of them being earmarked both formally or informally for health, social programs. And I think it's important to look at this from both an NCD prevention and financing perspective. So, and another conclusion of this work was the importance of policy coherence in the fiscal space. So, for instance, we can be taxing alcohol products, but if we are simultaneously subsidizing its production, as it still happens in the EU and many other places, that creates a huge contradiction that undermines public health goals. So this is a key message at the moment in our advocacy, and wanted to share with you. So I'm just gonna go into my last part of the presentation. It's regarding a little bit what we do at the global level. So I appreciate this was more about the messaging we're bringing, but how can we influence policy globally? And I appreciate, there are very few not binding outcomes at the global level, like the Framework Convention on Tobacco Control, and most of the commitments that happen globally are non-binding, but it is still important to create momentum globally. So one example has been last year's UN high-level meeting on NCDs and mental health, where we had a political declaration as the major outcome. And I just want to flag the importance of this was bringing head of states and governments together, because that creates cross-sector commitment. And at the end of the day, many of these policies are not implemented just by the Ministry of Health. And the outcomes were very mixed. The resulting declaration had, there were still a lot of reluctancy around acknowledging commercial determinants of health, and the commitments on prevention, especially health taxes, were very weakened during negotiations. On the other hand, we had targets as well that were adopted that can have a positive impact on prevention, but it will also depend a lot on how we hold governments accountable across them. My message here from an EU perspective is that the EU play an active role during negotiations, and it is crucial to understand how the EU as a bloc, so across member states, but also on behalf of the European Commission, positions themselves on these issues globally. And the next slide is my last slide. I just want to kind of show the kind of policy cycle in a very simple way, obviously, where we engage and how we look at it from a global perspective. So, and I just wanted to flag a few opportunities that are coming up to provide a bit of a more tangible example of what we are doing. So we obviously always try to start with building political commitment. We already have many areas where there is political commitment, but there are some emerging areas where we don't see yet. And one is, for instance, ultra-processed food. So tackling ultra-processed food as products that have an additional layer of unhealthfulness. And then the next stage is the technical guidance. Usually there is also policy guidance in many aspects of the NC response, but in others we're lacking. So for instance, alcohol labeling is one. NCDA is an observer of Codex. And for instance, next week, the Labeling Committee of Codex will be discussing potential new work on clarifying how food labeling standards apply to alcohol. And this would be a major milestone. And then also in 2 weeks, we have the World Health Assembly at WHO, and a strategy on economics of health for all will be discussed and adopted. And this touches on how we align public health and economic policy, also very relevant to what we're talking on. And mindful of time, I might not go through the whole thing, but just to show, for instance, on resourcing, a major gap. To say, for instance, NC financing has been gaining more and more attention, especially given the current AIDS crisis. And this year, we're being very active on an international dialogue on NCD financing that will take place in the Philippines with WHO. And then also implementation happens at the national level, but there is a lot we can do globally in terms of maintaining momentum and applying pressure. And here I'm showing the example of how the alcohol labeling, alcohol warning labels will look in Ireland. These were originally planned for this year for implementation, but now it has been delayed to 2028 after industry pressure. And this is just to show how important it's also to keep that pressure on the country for implementation, not just nationally, but regionally and globally as well. And finally is the accountability aspect of the policy cycle, that there is also things happening globally that are relevant. And for instance, we have global NC targets as part of the global NC monitoring framework that have expired last year. And it's important to be keeping track of how they will be extended to strengthen the indicators on alcohol and healthy diets. And just my conclusion is that it's important to identify where civil society needs to act across these levels as well at the EU level, and to realize, in order to realize the Safe Hearts plan. So with that, I just want to thank you. I hope this was helpful and I didn't go much over time. Thank you, Alexander.
Not at all, Liz. Thank you. It was super interesting. And yeah, I enjoyed listening to you a lot. So until we have some questions from the chat, I made some notes like classical way, pen and paper. And let me maybe summarize some of the key facts that I wrote down listening to Romana first. So she presented the the EU Safe Hearts plan, and that it started in December 25, but it's only a starting point, and it focuses on prevention. And I really liked that she highlighted those commercial determinants that we also did, which are not an individual responsibility, and that choices are not made in vacuum. I really like it, and that the environment pushes individuals in the opposite direction. And I think those are really great points. Where women's cardiovascular health, also a very important point, because really the symptoms are really different regarding cardiovascular diseases. There is even like a study that highlighted this, not only one study, but there are studies that highlight this, that we as physicians have to know better to look for symptoms in cardiovascular diseases that women have. And then I also like this topic about inequalities between member states, which is indeed in Europe, but also on a global scale, a very important point. And then there are not only shared risk factors, but also shared biological pathways, for example, through inflammation, which we as physicians see all the time, that if you have chronic inflammation, after a while, this can lead to cancer. And another important topic that Romana mentioned is that health is marginalized in the EU budget, and that she needs our help as scientific communities to push towards the direction that health is appreciated more and also gets the appropriate funding. And what I wrote in from your talk, Liz, until we get more questions in the chat, is that NCDs are the biggest killers, and that's true. It's a collection of very important diseases, and that also a large part of it is preventable. And as far as I know, regarding GI cancers, I think I read numbers about 40% of gastrointestinal cancers can be prevented, which would be amazing. I mean, all of my patients suffer so much under their disease and all the treatments they have to get, but also the psychological burden from every staging that they get is also impacting them a lot. And that also domestic budgets are misaligned with the scale of the problem. That's a really nice phrase. And then what I also really like is the harmful use of alcohol, that we have to be careful because there is no safe level. Indeed, when I talk to researchers that focus their whole research around alcohol, it's actually toxic for cells per definition. So there is no safe alcohol consumption. This was also a very important point. And then the commercial determinants, again, with highlighting those multinational companies that are like in the middle of it, and that I'm pretty sure that the argument is that it's about jobs. But on the other side, as you already nicely stated, healthier population is also results into more productivity, because people are not on sick leave. What impressed me most are that the children. I mean, it's not impressive that children are most vulnerable to this marketing, but it's really sad to see like a famous football player there where I would really guess that a lot of people would like it's like the hero for many children, and then it's like, oh, and you have to eat those chips and drink this Coke. So yeah, indeed, this is really a problem, and front of packaging labeling is also very important. And I recently, as a preparation for this webinar, I discussed with my partner like those topics, and she was like, "But we have it." And I said, "No, we don't have front of labeling packaging, front of package labeling. Look here and here." And indeed, it's like you said, it's voluntary. So, and this results in many companies not doing it, or like, yeah, and this is really something we maybe have to change. So maybe let's start with a question. So, Romana, when I heard a podcast of the NCD Alliance in preparation for this, or not only one, for this webinar, and there was a very nice phrase. It was about obesity, and they said that we are now with obesity where we were with tobacco use 20 years ago. So in the end, in my opinion, tobacco, so like the prohibiting people from smoking is a success story. When I look in my environment, when I was young and now, very few people are smoking now. And I guess it's we can see this in studies. So what would it take to implement the same measures that we did for tobacco, for prohibiting people from smoking? To implement this in healthier diets, I don't know, get rid of ultra processed foods. What would it take to take exactly the same road, or is it not like feasible? You're still muted.
Sorry. Well, what do we need to obtain the same result, the same success? Well, I think the main point is political majority and political will. Okay. And at this point, I can tell you from my experience as a rapporteur for cardiovascular health, I'm trying to put a strong emphasis on prevention, because as Liz also rightly said, and Liz, I liked your presentation very much, because it really reflects all my thoughts and all my concerns on NCDs in general, and especially at cardiovascular disease. The industry is so strong as a lobby. They are very strong in the European Parliament, and I see that they shape policies, and it's will be very difficult to change it. When I'm trying to put emphasis on prevention in the European Parliament, I encounter a strong resistance by the conservatives. The conservative group are the huge problem. They told me, you're against industry. And I'm trying to explain that I am not against industry. And talking about prevention and responsibility of the industry is not discussion about being for or against industry. It's discussion about public health. And as we perfectly know, a great deal of diseases can be prevented. We are spending billions and billions of euro every year, not to mention loss of productivity, disabilities, and so on. So it is our responsibility of policymakers to make a right move, and the right move would be to invest in the prevention. And here I'm talking about front pack labeling. I'm talking about finally admitting that there is no safe level of alcohol. For example, now I have a huge problem with the conservatives in the parliament to finish during the negotiations on the cardiovascular report, because they insist on this wording harmful level of alcohol. You know, industry is never static. They all innovate all the time. So I'm not talking about banning. We just need to put industry on the table and to try to find some compromise. If they do not feel responsibility towards children and the general population, then we must make them act responsible. The children are not informed consumers. They cannot be. They are very sensitive population. So I am trying to raise this issue in the European Parliament, but without the support of the right-wing groups, unfortunately, I must tell you that we will fail.
Thank you. I think it's great that you shared this, that you're not like alone responsible to make those decisions, and in those democratic processes, there are different voices. Anna from the UEG headquarter, I guess she wants to read out one of our questions.
We have 2 questions in the chat, exactly. The first one is, I can read it out loud. The fact that some countries have geographically differences in their healthcare systems, would or will it be a limitation to EU plans for healthcare?
Well, that's the point. So we are already aware that inequalities persist, that access to advanced diagnostics and specialized care and prevention programs is critically uneven. And the Save Heart plans need to deal with this problem. I know that Commission's plan, the Commission intend to develop a European cardiovascular health inequality dashboard that is modeled on the European Cancer Inequality Registry. And based on existing data. So they plan to invest in research under the Horizon Europe to advance the understanding of these problems and to deal with them. I think that EU level action can add value through coordination, through funding mechanisms, through research support, guideline harmonization, and capacity building in lower resource region. So yes, I mean, the Heart Safe plan has a very clear goal regarding the inequalities and how to tackle these problems. I mean, that's the point.
Now, do you want to read out the second question also?
Yes, exactly. The second question is, to what extent do you think current office working structures and prolonged sedentary work contribute to obesity and digestive health related NCDs? And should workplace policies be more explicitly included in prevention strategies?
Is this for me or for Liz?
Maybe Liz can answer this one. I think it's a super important topic because if you talk about reformulation, it's one thing that's maybe easier to tackle. But yeah, workplace policies, I'm super curious about your answer, Liz.
Sure. No, I mean, that's a very good question. Thank you for it. I think there are two questions there. There is one about sedentary tendency for sedentary behavior, and then the question about, what's the role of workplaces. I think in terms of sedentary behaviors, it's important to look at all the different structures that lead to physical inactivity, and physical inactivity is a major and serious factor. I didn't touch necessarily much on my presentation, just because also we wanted to focus also on the commercial determinants, etc., and physical activity is a bit different. But just to say, it's looking at how our workplace influence that, but also our environments more broadly, like the lack of green spaces, the expensiveness of going to a physical activity facility like a gym, etc., and what type of policies we can develop that encourages that, not just at a national level, but also city level. For instance, physical activity is something where local action is very crucial. I think when talking about the workplaces, we were talking about the importance of working across sectors for promoting health, education sector, etc. When it comes to workplaces, obviously there are public regulations that can make compulsory for companies to consider certain, or other institutions to have certain considerations. But what I want to say here is that the NCD response is also a multi-stakeholder response. So companies also have an obligation to look at how they can promote health in their own, if they have a canteen, how they can provide good, procure good options, healthy options of food, and therefore also opportunities for physical activity within the facilities of work, or also in terms of support, financial support for going to gym, etc. So obviously there is a wide spectrum of what to look at for promoting physical activity, and also the role of workplaces.
Alexander, if I just may add that also in a Safe Heart plan of the Commission, but in my report on cardiovascular strategy, we highlighted this importance of lack of green spaces, unsafe conditions for walking and cycling, which contribute directly to heart diseases. We call on public investment, in healthy urban environments that promote physical activity and reduce cardiovascular risk. So the emphasis is. The emphasis is on the need for guidance and policies to increase physical activities, education on that, and the opportunities for physical activity before, during, and after the school day, as well as throughout the adulthood. So we put a strong emphasis on physical activity, but we haven't mentioned, it's directly connected to sedentary way of life.
That's a very good point. Yeah. And it's a totally different way to tackle the problem, because one is like what ingredients is in your food, which you cannot decide, because already half of the energy intake that we have in Europe nearly half is already through ultra processed foods. But like how to, and maybe policymakers can influence this so that you have a more easier choice to get like the right food, but the other one is also like very, very difficult. How can you get somebody? We all work more and more in front of monitors. How we can get people to stand up and do the exercises? Great topics. And we have now 1 hour webinar. So the 1 hour is up. Anna, are there any other questions in the chat?
No questions, no.
Again, a very small remark from my side. Please read those two UEG position statements that Anna will put in the chat, or already put in the chat. She will put it in the chat. It's really impressive. I mean, we have data on this. In Israel, there was a tax on sugared beverages, And I think the prices went up. Let's say I read something about 17%, and the rate of consumption dropped to like by 30%. It was impressive. And then policymakers decided to take the taxes back. And then consumption went up again. So it's a study that was published this year, and we also mentioned this in our statement about transforming food systems for digestive health. It's really worth reading it because we have data on how much impact we could have through laws. So thank you again. I'm very happy that you participated, Romana and Liz, and thank you to all participants. I hope you learned something, and you turn on into our next webinar on digestive health.
Thank you.
Thank you all. Have a nice day.